The voice, James T. Helsper of the University of Southern California School of Medicine.
We welcome you to the symposium, Adventitious Therapy Enhancing Survival in Breast Cancer. For those of you who aren't semanticists, the word adventitious means supplemental in a scientific manner. It, of course, consists of radiation therapy, hormone ablation or manipulation, and chemotherapy. The standard of therapy was first devised almost simultaneously by Dr. William Halstead and Dr. Herbert Willie Meyer Sr. in the 1880s. Since that time, very little has been presented to actually change the standard radical mastectomy. However, the pendulum has swung during various decades to somewhat less and somewhat more surgery at times, and it is only in the last 20 years or so that these supplemental forms of therapy, the subject of our program today, have come into the fore.
And in this edition of Audio Digest Surgery, Volume 16, Number 24, the week of December 24th, 1969, Dr. Helsper and his colleague, Frederick W. George, serve as co-moderators, introducing four knowledgeable guest speakers: Jerome A. Urban of Cornell University Medical College, M. Vera Peters of the University of Toronto Faculty of Medicine, Arthur I. Holub of the American Cancer Society, and Malin R. Dullinger of the Pasadena Tumor Institute. To begin, here again, Dr. Helsper.
Our first speaker is Dr. Jerome Urban. Dr. Urban.
We'll lead off with discussion on surgical treatment of breast cancer. I think it's important to realize before we start that success in this field depends probably more on the stage of development of the tumors we're dealing with than on the method of therapy which we offer the patient, and they both have to go together. There's been a resurgence of disagreement on what constitutes the optimum therapy of breast cancer. 60 years ago, they were arguing about the same problems at that time. Now, with radiotherapy, the big advantage of radiotherapy, as we see it, is that you can cover a wider area than you can practically operate upon. The disadvantage is the fact that some tumors are not radiosensitive. The matter of selection is very important. Data from two authors, both at Presbyterian, Gutman with better material has a 50% 5-year salvage with aggressive X-ray therapy, while Atkins with more advanced material has only 21%. So that whenever we compare statistics, it's very, very important to realize that the baseline, the quality of material involved has a great deal to do with the result. And it's very, very difficult to compare material from different areas and treat it in different manners. We will pretty much try to give you our own philosophy of the surgical approach to the treatment of primary breast cancer. It's based upon this anatomical complex. The breast, the tumor in the breast, the peripheral regional node areas are the areas where cancer can be present and still curable by current means, surgery plus X-ray therapy. Anatomically, 3/4 of the drainage of the breast goes to the axilla and 1/4 to the internal mammary nodes. And clinically, it has been shown without doubt that the closer the primary tumor rises to the midline of the body, that's to the sternal portion of the breast, the higher the relative drainage of metastasis into the internal mammary nodes. So that when we have parasternal primary lesions, we find the same incidence of internal mammary metastasis as we find axillary metastasis. When the lesion presents in the outer part of the breast, the proportion drops off and the axilla is the primary drainage point. On this basis, we have used three general methods of treating different clinical status of breast cancer. When we fortuitously find a non-infiltrating intraductal or an in situ lobular carcinoma, the big problem is to ensure removal of all the breast parenchyma, because all of these lesions are multicentric in origin and they do not have the ability to spread to the peripheral nodes. And in this case, we do a simple with a low axillary dissection and always check the specimen at the time of surgery to be sure there's no infiltrating cancer in the breast. If that is found, we would proceed to do a radical. For the great majority of patients with outer upper quadrant cancers of the breast, approximately 2/3, we do a classical radical mastectomy. And for the patients with a high risk of internal mammary disease, lesions arising in the inner half and central portion of the breast, we do the extended procedure. If we find a great deal of nodal disease, or if we have a huge tumor in the breast with invasion of the pectoral muscle, we don't hesitate to supplement our surgery with X-ray therapy. Now, in doing a radical, we found a couple of steps to be helpful in the surgical management of the patient. Formerly, we were under the impression that the rectus sheath contained lymphatics which ran down to the round ligament and thence into the liver, and this has been proved to be not so that there isn't much point in removing rectus sheath below the costal margin. And we now clear the sheath up to about the level of the sixth rib, then transect it and peel up the sheath in order to get a nice approach to the pectoral major muscle. This method avoids a diastasis, which can be very troublesome. Now, in the upper portion of the operative area, we usually preserve the clavicular head of the pectoral major muscle, and we usually divide the muscle by finding the normal plane between the two heads beneath the head of the clavicle medially. It's very easily found, and one can separate the muscles cleanly in the normal anatomical plane, and then isolate the tendon of the muscle at its attachment to the humerus and cut it. This gives us a very nice approach to the axilla. We proceed further in this area, and we transect the clavipectoral sheath, which is a filmy sheath that covers the axilla, from its attachment to the coracobrachialis muscle laterally, cut the tendon of the minor at the coracoid. The minor muscle is enveloped by the sheath, and then proceed immediately and cut it from the subclavian muscle. And then you can sweep this down and get a very nice approach to the axilla and really clean the area out en bloc very neatly in a monoblock fashion. When we find cancer in both breasts, we treat both sides at the same time. We'll do a simultaneous mastectomy. Now, during the extended radical, our own feeling is that when you feel palpable nodes in the base of the neck, if you can prove that they are metastatic, they represent retrograde lymphatic permeation, and probably this patient is not curable, since the lymphatics probably have already drained into the large venous complex behind the head of the clavicle, and the lymphatics are plugged with tumor in that area. Occasionally we will do a simple on a patient like this and supplement it with X-ray therapy. Almost never do you get long-term survival if you prove the nodes are positive in the neck. If you have palpable nodes, that is a different story. They may not be involved in metastasis. You have to prove whether they are or not. At any rate, we concentrate our extended approach on the medial and central lesions. In doing the extended radical, we preserve all the features of a good classical radical mastectomy. Adequate skin excision around the tumor margins, thin flaps staying out superficial to the superficial fascia when you're over the breast parenchyma, and proceed as you would with a radical in the beginning. We cut through the rectus muscle over the sixth rib. Below and above, we isolate the first interspace below the first rib and the arch of the manubrium. Insert our fingers beneath the pectoral major muscle and isolate the parasternal attachment of the muscle. And this helps us to decide how much of the chest wall to resect, because we're interested in getting the lymphatic drainage in that area. Ordinarily, the parasternal attachment of the muscle corresponds to the area just inside the costocaudal junctions to close to the midline of the sternum. And then you have a slip running along the fifth rib below, which is usually not accompanied by very much lymphatic or vascular drainage. Open the interspaces above and below. We're cutting through the sternum with a sternal knife, and then we cut the ribs and the intercostal tissues at the level of the costocaudal junctions laterally. We do this in an en bloc fashion while the chest wall portion we're resecting is still in continuity with the overlying breast. There's no separation between the perforators and the internal mammary vessels. You can actually do a better en bloc excision in this way in the internal mammary areas than you can in the axilla. Now, the big problem was to repair the defect because we create a hernia in the chest wall, and we found the optimum closure has been obtained in this manner. We use permanent sutures of number 2 dermalon and overcorrect the defect, running a mattress suture across each rib to the opposing surface of the sternum. And we usually diminish the defect by about 1/3. This stabilizes the chest wall and prevents paradox. And then over this, we place a prosthesis of sterile ox fascia, although you can use the patient's autogenous fascia lata equally well. And then after completing repair and having inserted an underwater catheter in the chest, we complete the radical, cleaning out the axilla carefully, preserving the long thoracic, usually sacrificing the thoracodorsal nerve. We usually obtain primary closure. I think the old idea that you had to graft everybody is sort of a fetish and goes back to the time when average cancer was about 20 cm in diameter at the time of Halsted. Nowadays, when your average tumor is about 2.5 cm in diameter, I don't see anything to be gained by primary skin grafting. And our local recurrence rate would demonstrate no increase, in fact, very good local control with this approach. Now, I think the main thing we have accomplished in doing this procedure is to document the fact that a fair number of patients have spread into the internal mammary nodes, and that a good proportion of these patients can be salvaged. And this is true whether you prefer surgical excision or aggressive X-ray therapy. The main point to get across, I think, in this field is that you should treat the internal mammary nodes as well as the axillary nodes. Just don't forget about them. At any rate, with the selection of patients with a high risk of internal mammary nodes, a third of our patients had disease in this chain of nodes, and only a half had disease in the axilla. And with the same selection, almost 16% of patients with a negative axilla had positive internal mammary nodes. This is higher than the average. If you took the average group of patients being seen, included a lot of the outer quadrant lesions, the relative take of internal mammary nodes would probably drop to about 10% in the overall group. So we don't see much point in doing this more difficult procedure on patients with a very low risk of disease being in there. At 5 years, we have 470 patients, and in this group, 65.7 are free of disease at 5 years. 73% are alive. The interesting thing here, to me at least, is that we have approximately the same salvage rate in patients who have only axillary involvement as in those who have only internal mammary involvement. In the only axillary involvement, 69% survived. Only internal mammary involvement, 67% survived 5 years. And our local recurrence rate was 6.6%. This includes most local recurrences which appeared after the patient had developed systemic disease. Very few of these were local recurrence per se. When we have disease close to the periphery of our surgical excision, we do not hesitate to supplement our surgical attempt with aggressive supravolage therapy. We usually use cobalt-60 and give 4,500 rads in 5 weeks. And in this situation, mostly to the base of the neck and the upper end of the internal mammary chain. And as you would expect, the patients with more extensive disease are the ones who get X-ray therapy, and they also get poorer salvage rate, mostly because the disease is more extensive, more likely to have systemic disease. And the group that had no X-ray therapy did quite well, 62% alive at 5 years. And a lot of these patients had disease in internal mammary as well as axilla. At 10 years, we have comparable figures. Again, only axilla, only internal mammary, the same salvage rate in both groups. And it was very interesting in this material that we discovered that 9% of the patients originally undergoing extended radical developed a new cancer in the opposite breast within the 10-year interval following their initial surgery, which was really an eye-opener to us. Now, although we've gotten a reputation for being rather radical, we really appreciate finding something very early, and we can do procedures that are more cosmetic and pleasing in appearance and still cure these patients. A patient with a very early superficial Paget's, where there was no thickening of the breast duct system beneath the nipple. These patients usually have non-infiltrating intraductal cancer in the duct system and Paget's in the nipple itself. And we've treated a number of these patients with a modified radical, so-called simple, with good flap dissection, the same as you would with a radical, good axillary dissection, but preservation of the muscles. And the only defect in this is that we cannot get the apex of the axilla as we can with a radical. It's the type of lesions we've applied this to, almost primarily patients with non-infiltrating cancer, and these are not patients you include in your 5-year statistics as you do. I think you should limit your 5-year statistics and 10-year statistics to infiltrating cancers. But we're seeing more and more of these early cases with all the agitation about early diagnosis, the influence of mammography, cancer detection clinics. It's a very healthy situation, and I'm more excited about this than any other aspect of the treatment of breast cancer. At any rate, here are 140 operations. All these patients are free of disease, except 3 now who died of other causes. Not because this is a terrific operation, but when it's so early, the lesions can be salvaged in this manner. This is the advantage of the modified approach. Preservation of the pectoral muscle retains the normal architecture of the axilla, and this certainly looks better than a patient with a big hollow up there. I think it's important to get across, though, that I personally don't think this is a good operation for the average patient with an infiltrating duct carcinoma, because what you're interested there is in getting all the tumor out, and you certainly can do a better job in the axilla if you take the sternal portion of the pectoral major and the pectoral minor muscle out with the specimen. The minor is the muscle that really covers your axilla, and you just can't take the apex out well without sacrificing the muscle. But in special situations, this is all right, I believe. Now, with this approach in our own practice, we find that between 1957 and 60, including all the patients seen with previously untreated breast cancer, we operate on 93% of our patients were considered operable. And in the operable group, 2/3 underwent a radical, 1/3 an extended radical. The axillary involvement in the radical group was 46%, and the extended radical 54%, a little more advanced. Yet the 5-year salvage are practically the same, 76, 74%. This is survival, not necessarily free of disease. And the overall group of operable patients was 75% 5-year salvage, only 2.5% local recurrence. And in a lot of these patients, we did supplement surgery with X-ray therapy when we thought it was indicated. In our inoperable group, they're really inoperable. None of them survived 5 years. We had a lot of local recurrence. And we had 20 patients with non-infiltrating cancer in this interval. They're all free of disease. And this is what we're really after, and we're getting more and more in this category. And 3 types of recurrent breast cancer can be salvaged long-term wise by local therapy. The 3 types would be the parasternal recurrence coming from an internal mammary node metastasis, a solitary recurrence in the flap, and a recurrence in the axilla. All of these can occur by direct lymphatic drainage from the primary tumor without the necessity of having systemic disease. You don't throw your hands up when you get a solitary recurrence. You ought to go after it very aggressively, either by X-ray therapy or surgery. These are not the patients that you do an adrenal or a hypox on.
Dr. George.
Our next panelist is a radiotherapist. She'll be presenting an analysis of the largest series of breast cancer patients ever recorded from a single cancer management center. Our panelist, Dr. Vera Peters.
During the course of a long experience as a radiotherapist treating cancer of the breast, one constantly weighs the good effects against the bad effects in both surgery and radiation and observes their results in individual cases. Gradually, clinical impressions of the most suitable methods of treatment in each stage evolve, but a period of reckoning to prove or disprove one's clinical impressions eventually becomes mandatory. Hence the present survey of cases of breast carcinoma, treated or followed in our institute since 1938. At the Princess Margaret Hospital, Toronto, the records of 8,481 successive cases of breast cancer presenting up to 1963 have been reviewed. All the survival rates at 5, 10, 15, and 20 years have been corrected for the natural survival decline according to the age distribution within each risk period. A modification of the International TNM classification has been employed, and whenever the primary treatment included an axillary dissection, the final staging in this series has been based on the histological extent of disease in the axilla. In stage 1 breast disease, the corrected survival rates at 5, 10, 15, and 20 years show very little difference between the methods of treatment, and any irregularities are usually on the basis of low numbers. But in this particular series, radical mastectomy followed by radiation has the most superior survival, but this is because of the selectivity in our particular series. All the patients were referred for postoperative irradiation, but the postoperative irradiation was not given if they were poor risks for the second procedure, if the incision had not healed well, and if they were very elderly or had some other condition such as diabetes, which would have entailed a risk. So that our MR is not like a surgical hospital. The results are lower, and it's because of the selectivity. It's because these are poorer risk patients than the patients who did receive both measures. And in stage 2, very comparable picture. Now, a more uniform comparison appears when stage 1 and stage 2 are combined. Only the simple mastectomy group shows a poor rating after 5 years, but the patients included were elderly and sometimes unable to tolerate a second major therapy measure. Apart from the MS group, there is very little difference in the corrected survival rates up to 20 years. Now the picture changes somewhat in stage 3 disease, because the less frequently prescribed methods of treatment come to the fore, and the more frequently prescribed methods have apparently a slightly poorer survival rates at up to 20 years. Believing that some of the differences in the survival rates according to method of treatment were due to the selection of cases within each stage, the crude survival rate by T&M grading was estimated, and in the reductions in survival rate consistently parallel the increasing extent of disease, with one exception: T3NO-MO, the highest level of stage 1, has a slightly better 5 and 10-year survival than T2N1-MO. Otherwise, the survival rates drop in a step-like fashion. Thus, selection according to extent of disease is extremely important, both in prognosis and in comparing responses to different methods of treatment. This clinical experience in breast cancer is significant because of the large number of successive cases reported. Also, the reasons for the choice of treatment are known because the author shared this experience. In the aura of pessimism about cures in breast cancer, it is gratifying to pinpoint a few areas in which cures are apparent. The suggestion of cures in certain age groups makes the search for optimum methods of treatment worthy of pursuit. An artificial menopause prior to the onset of breast cancer appears to have had a favorable effect on the survival rates up to 20 years in this series, but the explanation of this finding is obscure. The better response rate in the group which had an artificial menopause may have a twofold explanation. Firstly, due to the artificial menopause, the corresponding postmenopausal group is younger. Secondly, the previous removal of the major estrogen influence may have enhanced their resistance to the disease. The good artificial menopausal influence persists up to 20 years after treatment. In fact, it becomes increasingly more prominent at each 5-year period after treatment. This area requires more study because there is considerable imbalance in the age distribution of the two postmenopausal groups. After an artificial menopause, the disease rarely occurs in the 60-plus age group. The survival rates at 15 and 20 years appear to be highest in the youngest decade, that is 20 to 29. But on reaching the menopause, these patients are prone to relapse. In the search for better methods of management in early breast cancer in this series, the higher survival rates in the 589 patients who had an excisional biopsy, a short interval before radical treatment, is of particular interest. Certainly, this method of management, the preliminary excision, followed by a short delay before elective major therapy, is a simple and safe addition to the presently accepted methods of treatment. And this plan of management sequence allows due consideration of all important histological features before radical treatment. Also, the patient would not have to cope with two shocks at the same time. First, the realization that she had breast cancer, and then the unpleasantness of the major procedure. The superior rates of response in this rather unique experience leaves 3 questions to be asked. After the breast lump is removed, does the short delay before major treatment allow the patient's acquired immune reaction to exert a favorable influence? Does the preliminary excision eliminate the risk of showering the bloodstream with malignant cells during a prolonged surgical procedure? Or, in other words, does the preliminary excision reduce the risk of metastases. Did the preliminary excision allow better clinical selection for further treatment? The results suggest that a simple excision of the breast lump could prove to be a useful method of sorting out favorable prospects on a clinical basis, but the period of delay could be used to advantage for clinical and histological assessment to provide a better prognostic index for each individual patient. Certainly, the prevalent concept that a previous excision is a hazard to survival in breast cancer becomes a myth. After the primary breast lump, which proves to be carcinoma, has been removed, there is a much larger choice of major therapy. Because cures are apparent in this series in all three stages, it seems important to eradicate the disease in both the breast and the regional lymphatics whenever possible by the most suitable method for each patient. Radiation therapy and surgery appear to be equally effective in the control of early disease in the axilla, but radiation alone, according to this series, appears to be inferior to surgery alone in the eradication of disease in the breast, unless the primary lump has been excised. After a radical mastectomy, a harmful effect of added radiation could not be identified in this study, but the necessity of both measures is questioned in early breast cancer.
We had one question of Dr. Peters. Would not those patients who had a preliminary excision represent those who were considered benign preoperatively and therefore represent a group who would normally have a better prognosis in any case? Dr. Peters?
No. The answer is no, because the majority in this series that had previous excisions were from the country, and there were patients who just refused to come to hospital until the necessity was proven. They were of the same grading, the same TNM grading as the rest.
I have a question, Dr. Peters.
Yes?
What is the recommended interval after excision and before definitive therapy?
I studied this once before, and I think about 10 days seems to be the ideal. I discussed this method of treatment with one of our surgeons about 4 years ago, and he started it and is exceedingly pleased. So far, he hasn't run into any troubles.
Excuse me, panel, long enough to say that this doctor concludes this side of your reel. On side B, the continuation of this program on adventitious therapy enhancing survival in breast cancer. Simply reverse the two reels or cassette on your tape recorder. This is side B, Audio Digest Surgery, volume 16, number 24. Continuing a program on adventitious therapy enhancing survival in breast cancer. Here again, Dr. James T. Helsper.
Our third panelist, Dr. Arthur Hollop.
I'd like to make some rather dogmatic statements to stir up some controversy among you. First, I would say that ablative endocrine surgical procedures should be reserved for patients whose breast cancer is widespread and progressive, or at least so locally extensive that radiotherapy is of no value. In other words, if the disease is not systemic, systemic therapy should not be used. Next, I would like to dispense with all considerations of prophylactic therapy with the statement that hormone therapy, castration, adrenalectomy, and hypovolsectomy are not to be recommended for patients who do not have proven evidence of locally recurrent disease or distant metastases. Also, since oophorectomy, the first step in the treatment of the premenopausal patient, gives the most valuable information concerning selection of subsequent therapy, the prophylactically castrated patient appears to be at a disadvantage when there is recrudescence of disease. There is no sure and simple test for predicting the course of breast cancer and its response to therapy. As one reviews the literature concerning the effectiveness of various procedures, it becomes readily apparent that a little more than 1/3 of all patients with metastatic breast cancer will show significant regression of disease when ablative surgical procedures are used. Now, if we divide the patients into two major groups, the premenopausal and the postmenopausal, we would also probably agree that the initial recommendation for a menstruating patient is castration, preferably by oophorectomy. Radiation castration may be performed on patients who refuse surgery or cannot tolerate a surgical procedure. Surgical removal of the ovaries produces an immediate effect, while radiation castration may require 6 to 8 weeks to suppress ovarian function. The overall regression rate for castration is in the neighborhood of 30%. However, the response rate is considerably lower for patients with rapidly growing cancer, extensive hepatic metastases, lymphangitic pulmonary metastases, inflammatory carcinoma, and brain involvement. If there is a good objective response to castration, no additional therapy should be given until this control is lost. If the problem cannot be managed by local surgery or radiotherapy, adrenalectomy or hypovolsectomy may be considered at this point. About 40% of the oophorectomy responders will then show a second remission to further ablative surgery. I hope you've all had the opportunity to read the October 1967 issue of SG&O, which contained a report of the results of adrenalectomy from Memorial Hospital in New York. This is a report on adrenalectomy for advanced breast cancer and deals with 500 consecutive patients. It is, to my way of thinking, as unbiased a report as you will find anywhere in the literature. In this study, emphasis was placed on the importance of evaluating patients in terms of the duration of the free interval, the physiologic age of the patient, the location and extent of metastases, the rapidity of growth, and the effectiveness of earlier therapy. Prior to major ablative surgery, pleural effusions, mild hypercalcemia, impending pathological fractures, and severe anemia, of course, should be noted and corrected. If the patient has already received hormone therapy, one can wait several weeks to see if a withdrawal response occurs when that hormone therapy is discontinued. A complete battery of biochemical determinations should be performed preoperatively, as well as thorough radiologic surveys. Vaginal smears may be of some help in estimating estrogenic activity, although there is considerable question about the value of the vaginal smear in determining the response of the patient to major ablative surgical procedures. The use of the so-called discriminant function, which describes the relative proportion of etiocalanolone, largely derived from adrenal dehydroepiandrosterone and the 17-hydroxycorticosteroids, appears to be a promising attempt to establish the endocrine status of the patient. Prognosis, both in the treatment of the primary disease and the management of its metastatic manifestations, can be related to the result obtained in equations which determine the relative proportion of these two substances expressed as urinary metabolites. Now, I won't burden you with the details of the equation, except to point out that a negative discriminant carries unfavorable implications and a positive discriminant favorable ones. This work of Bulbrook in England needs more evaluation, I think, before its routine usage as an adjunct in deciding the need or lack of need for major ablative surgery. The same also holds true for some recent work by Deo on sulfurating enzymes found in the breast cancer itself. Now, estrogenic secretion studies are rather difficult to evaluate, and the estrogen stimulation tests, unless very carefully supervised, can be quite dangerous to the patient when acute exacerbations are produced. The predictive value of vaginal cornification indices may be of some help, but I think only if high values are obtained. Now, for the patient who does not respond to oophorectomy, it is my feeling that further ablative surgery offers very little. About 17% or less of these patients will show a response to ablative surgery, but the morbidity and mortality rates are prohibitively high when one considers the extremely limited number of patients who will benefit. Most of the confusion about the proper management of disseminated breast cancer is due to conflicting reports on the effectiveness of different methods. The wide range of response rates is due to the varying criteria used for determining response. There must be careful delineation between subjective response and objective response, or one cannot compare reports. Different criteria for objective regression have been used, and the term arrest of disease muddies the waters even further. Another cause of confusion is the use of biochemical determinations as signs of objective regression. I think the simple criteria, such as the physical and X-ray examinations showing shrinkage of tumor without concurrent progression of old lesions or the appearance of new lesions, would simplify matters considerably. The so-called mixed response should be classified as a failure of therapy whenever it occurs. Standards have to be maintained for a minimum period of time to officially classify a procedure as a success. Objective response that lasts for 1 or 2 weeks following adrenalectomy or hypovolsectomy is hardly a therapeutic triumph. A minimum period of 6 months of objective regression should be used to classify a major ablative procedure as a reasonably successful operation. Castration, as you know, deprives the body of ovarian estrogens. Adrenalectomy removes the second source and the corticosteroids. By removing the source of adrenocorticotropic hormone, hypovolsectomy accomplishes the same effect as adrenalectomy. Since the remission rate of hypovolsectomy so closely parallels adrenalectomy, it would seem to me that the removal of other pituitary hormones does not influence breast cancer to any great extent, that is, the growth hormone and the lactogenic hormone. Objective regression rates following adrenalectomy or hypovolsectomy vary in the literature from 25 to 59%. But the range here probably results from the varying criteria used for evaluation and also the selection of patients. I think it fair to state that those patients who have responded to castration, when taken as a group, show an objective regression rate of about 35% for a period of time of 6 months or longer. Now, as we have become more experienced with adrenalectomy and hypovolsectomy, we recognize the need to exclude patients who have brain metastases, liver metastases sufficiently extensive to produce severe biochemical changes, the patients with myelocytic anemia, and those with severe respiratory problems. Also, the history of marked hypercalcemia may well make a patient a poor candidate for major ablative surgery. In the hands of experienced surgeons, the mortality rate of adrenalectomy has now been reduced to about 5% or less. However, the national mortality rate of the operative procedure is probably a lot closer to 9%, a figure which should encourage very careful evaluation before such a recommendation is made. The operative approach to adrenalectomy varies from one institution to another. If the patient is markedly obese, it may be simpler to perform the adrenalectomy through flank incisions. If the patient is slender and one wishes to do a combined oophorectomy and adrenalectomy, the transperitoneal approach is preferable, since this allows the surgeon the opportunity of examining the status of the liver. Another advantage of the transperitoneal approach is that the patient need not be shifted on the operating room table from one position to another, perhaps resulting in a pathological fracture of a lumbar vertebra or a hip filled with osteolytic metastases. Most hypovolsectomies in the past have been performed by the transcranial route. Other approaches now include the transsphenoidal, stereotactic procedures, radiation techniques, the use of fixative solutions, and even more recently, the advent of cryosurgery. I suspect that in time, many general surgeons and head and neck surgeons will be sufficiently trained in the non-neurosurgical approaches, and hypovolsectomy may become as common as adrenalectomy. There are specific contraindications to both adrenalectomy and hypovolsectomy. We've mentioned the patients with metastases to the central nervous systems, those patients with extremely low vital capacity secondary to pulmonary disease, certainly the jaundiced patients, those with hypercalcemia, and the myelocytic anemia patients. I personally would also exclude the patient with a very short free interval from the time of initial treatment, and those with so-called galloping cancer who rarely respond to any modality of therapy. It has been pointed out repeatedly that the longer the free interval from initial therapy to the first evidence of metastatic disease, the greater the chance for a good remission. Now, this factor of selection almost makes one wonder whether it is the slow-growing nature of the disease which accounts for a satisfactory response, or the major ablative surgical procedure which is being performed, or perhaps a combination of both. There is insufficient evidence to show that previous responses to androgen therapy, corticosteroids, estrogens, and chemotherapy can be of assistance in predetermining the response to adrenalectomy and hypovolsectomy. It's also rather difficult to know how much one can truly rely on the level of cornification in the vaginal smear to anticipate how well a patient will respond to these major procedures, except to say that I would certainly think twice about recommending a major ablative surgical procedure for the patient who has a completely atrophic vaginal smear.
Dr. George?
Our medical chemotherapy friends complain so interminably that they're always the last one in on these cases that we felt today that perhaps Dr. Dollinger, our next speaker, wouldn't feel particularly out of place if the anchorman on today's panel, Dr. Dollinger.
I'm going to talk about all of the patients that Dr. Urban and Dr. Peters and Dr. Holub cannot cure. First, the use of surgical adjuvant therapy for cancer of the breast. The data here is largely that of the Surgical Adjuvant Cooperative Group. Dr. Bernard Fisher in Pittsburgh has kindly let me use some of this information to tell you today. For many years, the recurrence of cancer has been attributed to the release of cancer cells during surgical radical mastectomy. Cancer cells have been demonstrated in the wound, in the blood and lymph draining the site of operation, and in the peripheral blood. Dr. Cole reported a 50% rise in recurrence rate in patients from whom tumor cells were recovered. In 1957, a group of investigators organized the Surgical Adjuvant Cooperative Breast Group, and they started using thiotepa, since there is some effectiveness of this agent in palliative treatment. This program was designed to evaluate the effect of adjuvant chemotherapy on the survival rate, on the recurrence rate, delay in recurrence, and toxicity. This was a double-blind, randomized study of potentially curable patients given the usual dose of thiotepa, 0.8 milligram per kilogram, half on the day of surgery and a quarter of that dose on the 2 following days. There were 3 parts to this, wherein the dose was temporarily lowered because it was thought to be too toxic and then raised again when it was discovered not to be. And the conclusion is that thiotepa is justified as the surgical adjuvant only in premenopausal patients with 4 or more positive nodes. As a result of severe toxicity seen after fluorouracil and the demonstration of lack of any therapeutic effect, and there was very little benefit from fluorouracil, it was recommended that FU not be used as a surgical adjuvant in the regimen that they had employed. Now, one word about complications of this method of treatment. In the 1965 report, there was a complication rate of about 30% in all of the patients. In some patients, with marked leukopenia, as a matter of fact, the code was broken, and these patients, in some cases, had received a placebo. Cohn reported the complications in the phase 2 study comparing 5-fluorouracil and thiotepa used as adjuvants, and this will summarize the phase 2 study as far as complications are concerned. For 5-fluorouracil, 42% developed a white blood count under 4,000, and half of these were below 2,500. Only 15% treated with thiotepa had this white count. Local complications developed in 52% versus 47% for thiotepa, but significantly, the early mortality, that is within 30 days of surgery, occurred in 1.2% of all of the patients, and that consists of 16 patients, 8 each on either drug. Of these 16, 9 of them had drug toxicity, 8 of them had evidence of sepsis. There were no deaths in 211 patients that received a placebo. So I would conclude that despite the demonstration that this type of therapy is effective in these patients with 4 or more positive nodes who are premenopausal, I think that in view of the toxicity we see, this type of therapy should be watched by someone who's experienced in the use of this type of agent, preferably in an organized cooperative study of some kind, in an attempt to learn something new about the use of this kind of drug. And this entire study has consisted of only 1 dosage regimen. Many others could be invoked. I'd like to go on now to the problems of hormonal therapy. And I might say at the outset that what I'm going to report here is one viewpoint. Many people have other ways of using hormones, particularly the order in which hormonal therapy and ablative surgical therapy are given. This data that I'm going to present is largely that of Memorial Hospital, which has been assembled by Drs. George Escher and Richard Kaufman. And as Dr. Holub stated so well, we would like to have a demonstration of systemic disease and progression before we will invoke any of this kind of treatment. We have to plan hormonal therapy as well as non-hormonal chemotherapy. as part of the total management of the patient and integrate this with the surgical and radiotherapeutic approaches to palliation of these patients. We would prefer to use hormonal therapy before non-hormonal, that is, cytotoxic drugs, because the use of non-hormonal agents is associated with toxic side effects, and because the remissions obtained are not generally as long as with hormonal manipulation if you succeed. This is not because we think the rate of response is any different if used as initial therapy. One other small advantage is that the use of hormones does not require the very close management and follow-up and blood counts that are required when non-hormonal chemotherapy is used. We would suggest the following pre-treatment baseline studies and follow-up studies of similar nature from intervals of 1 to 2 months in the case of the blood studies, and x-rays every 3 to 6 months. In particular, initially a chest x-ray measurement, and this is with a ruler, not in fingers, of palpable or visible lesions and photographs, a survey of the skeleton, calcium, alkaline phosphatase, protein, 24-hour urinary calcium, blood counts, including a platelet count, and if there's any suspicion of liver involvement, liver function tests. Again, before initiating hormonal treatment, it should be established that there is progression of disease, since even a disseminated disease may remain quiescent for a considerable period of time without any treatment. We would like to see, as a definition of response to hormonal treatment, decrease in skin, breast, and lymph node lesions, decrease in pulmonary nodular or lymphangitic lesions, or filling in of osteolytic defects without development of any new defects. We're very happy that performance status, neurological signs get better, that the patient is eating better, gains weight, better strength, but we don't regard these as any evidence that the hormone is improving the patient as far as the decision for continuing hormones. I'll talk about premenopausal hormonal therapy and then postmenopausal as a handy way to divide the subject. Again, up to 1 year following menopause, we regard the patient as premenopausal, and following a surgical castration, which is of course the first method of treatment, and we've seen 30 to 40% responses, we may use androgens in an attempt to provide another remission. And some people will use adrenalectomy or hypovolsectomy. I can find you many that will take either side of that question. The rationale for using adrenalectomy first, of course, usually is that if we give androgens and we fail, and it takes usually 3 months to determine if a response will occur, or to be certain it has not occurred, the patient may no longer be in a condition to tolerate a major procedure such as an adrenalectomy. Isolated metastases or local recurrences may best be treated with radiotherapy or surgical excision. Now, in situations in which a very rapid response is necessary, such as cerebral involvement, rapidly progressive liver involvement, we would rather use radiotherapy or non-hormonal chemotherapy. We will not use androgens unless the patient is likely to survive at least 4 to 6 weeks. 95% of the responses will occur within 3 months. And unless there is evidence of acceleration of disease by such treatment, you should continue androgens for this length of time. Now, many patients initially will show increased bone pain and a rise in the alkaline phosphatase. This is what we call an initial flare, and there is sometimes an elevation in serum calcium transiently. This may accompany healing, or it may accompany worsening of the bony lesions, and you should not withdraw androgens for this reason unless this is life-threatening. Sometimes by lowering the dose of hormone and appropriate analgesics, one can get the patient through the first 1 or 2 weeks, and usually these symptoms will subside. If you have a favorable response, you should continue androgens for at least 2 to 3 years as long as the regression persists. If the patient progresses, the drug should be stopped, and withdrawal may then result in a favorable response, which is what we call rebound regression. You can also use androgens in the treatment of the premenopausal patient who fails to respond to surgical castration, but the expected response rate is only in the range of 14%. Now, a discussion of postmenopausal patients. The initial therapy of choice for women 5 years or more past the menopause is estrogens, to which about 35% of patients will respond. And the response is better for local disease, that is chest wall and lymph node, 45%, compared to osseous disease, 29%, and visceral disease, 32%. The response to estrogens in the group 6 to 10 years postmenopausal is about 39%, 35% more than 11 years postmenopausal, and in the less than 1 to 5 year, that is the group during the first 5 years after the menopause, the results are considerably poorer with estrogens. In the late postmenopausal patients who are non-responders to estrogens, Or in patients who initially respond and then relapse, you may then try androgens. Also, in patients who respond to either of these and then relapse, you can still consider adrenalectomy or hypovolsectomy, which may result in improvement in up to 50% of cases. The response rate to these ablative procedures in the postmenopausal patient that does not respond to hormonal therapy is considerably lower, certainly no more than 25%. Again, remembering that X-ray therapy to local lesions may spare the patient's bone marrow and subsequent trials of chemotherapy. Now, there is one very difficult group, that is the patients from 1 year following the menopause to 5 years following the menopause. The optimum method of therapy has not been defined for this group. Estrogens, given as primary therapy, resulted in responses as high as 18%, but there is a very high possibility of exacerbation. The androgen response is about 15% in this group, but if you give androgens or estrogens following some other procedure, the response is even lower, about 9%. And you may get responses to adrenal steroids or non-hormonal chemotherapy. Here are the dosage schedules of the commonly used hormones. Testosterone propionate may be given 100 milligrams 3 times a week, or a derivative of this. Commonly, however, it's much more convenient to use a synthetic derivative, halotestin, or fluoxymestrone, in a dose of 20 to 40 milligrams every day. And this is about the same as testosterone as far as response. There are a number of estrogens which can be used. Diethylstilbestrol, 15 milligrams a day, ethinyl estradiol, and various other derivatives. And if the patient is intolerant of these orally, and sometimes there is severe nausea or vomiting, one may attempt to inject estradiol benzoate 3 times weekly in a dose of 5 milligrams. There are a number of side effects to estrogens and androgens that are quite disturbing to the patient. In androgens, including a change in voice, clitoral hypertrophy, edema and acne, hirsutism, hypercalcemia. Most of these can be tolerated. Hypercalcemia, if it is severe, requires that the drug be stopped. Edema can be treated with diuretics or low-sodium diet. You can't do much about polycythemia or hoarseness of the voice. If the patient is intolerant of these drugs by the oral route, you can give this after meals or try the intramuscular preparation. The estrogens have similar problems. In contrast to the androgens, patients may develop urinary incontinence, for which a pessary may be useful. Bleeding on therapy can be treated by increasing the dosage, or if it occurs on withdrawal, if it's severe, one can give ergonovine to stop this. Again, diuretics and a low-salt diet will manage the problem of edema. Hypercalcemia requires that you stop the drug, force fluids, and use a low-calcium diet, and if necessary, use corticosteroids. And now, lastly, I'll mention something about non-hormonal chemotherapy. Usually, I use these last because of the fact that remissions are not as long as with hormonal treatment. These can precipitate adrenal crisis in an adrenalectomized or a hypovolsectomized patient. And you should remember that you should increase the replacement dosage of corticosteroids if you put the patient on cytotoxic chemotherapy. Osseous disease does not respond to this type of agent. Cerebral disease does not. They do not penetrate the blood-brain barrier. Bone marrow lesions do not generally respond to this kind of agent. In some cases where you would ordinarily use hormonal treatment, we use instead non-hormonal chemotherapy in a few specific situations. One, if the patient is not expected to survive more than 4 to 6 weeks, you don't have time for an adequate trial of hormones. Second, lymphangitic pulmonary metastases, massive liver involvement with increasing jaundice, and so-called inflammatory skin recurrence. We also think, off the top of our head, that in a patient with very, very slow-growing metastases, that over a year's time, maybe 3 or 4 centimeter nodule becomes 4 or 5 centimeters in the lung, that the patient is somehow controlling her own disease by virtue of some body defense. We are a little reluctant to give hormonal therapy or ablative surgery in some of these people, and we think perhaps non-hormonal therapy will interfere less with the host defense. As far as alkylating agents, if you're in a hurry, that is, if the patient has lymphangitic pulmonary metastases, you should start with an intravenous agent, such as thiotepa, which we prefer to nitrogen mustard. Thiotepa does not usually cause vomiting. The patient does not have to be in the hospital, and its effect is predictable. You can maintain the response with chlorambucil, which is an oral alkylating agent. About 25% of patients will respond to thiotepa, and Cytoxan is an alternative. 5-fluorouracil is employed first if there is advanced liver metastasis, or second to alkylating agents in all of the other situations. And I'd like to point out here that the package insert that comes with the material I believe to be incorrect. The dosage there is too high. Originally, the dosage was 15 milligram per kilogram daily times 5. And this was subsequently revised for 4 days because many deaths occurred which were shown to be due to toxicity. We would prefer to use a dosage in good risk patients with good marrow, no previous cytotoxic treatment, of 15 milligram per kilogram daily for 3 days, and then a half of this dose, 7.5, every alternate day until the very earliest sign of toxicity. Even the earliest mouth ulcer must make you stop treatment. The white count need not fall. It may start to fall 2 weeks after the mouth ulcer appears. The difference between the therapeutic dose and the fatal dose may be 1 additional injection of fluorouracil. And this is the most commonly used chemotherapeutic drug, I think, around the country, and it's also the most dangerous. Vinblastine has been shown to have a response rate of 20 to 25% in various series, and we would use this drug after the other 2 types of agents that I've mentioned to you.
And this concludes this edition of Audio Digest Surgery, concluding also our 16th year of tape-recorded summaries from the most clinically useful postgraduate courses and meetings. Audio Digest Surgery is produced twice each month by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association, along with 7 other programs of tape-recorded medical information. All material in this program is copyrighted, and further tape duplication is expressly prohibited.